So team is all ready. So good afternoon, everyone. And this is the Hematology for All, a joint venture of ISHBT and IIM in Nashik. So Indian Society of Hematology and Blood Transfusion. Dr. Maitri is here, Prantar Sari is here, and all my senior teachers are here. So this is what the hematology is actually. ISHBT is about hematology for all. And thank you, Siddesh, for organizing such a grand event. We are in the last session of this meeting, and that is on DIC, disseminated intravascular coagulation. And this is the topic which is for all. So, true science, hematology for all. All of us, to some more extent, see these DIC patients in our ICUs, in our wards, in our routine practice. But many a times we diagnose and many a times we miss. So we have here our expert panel available to us to discuss about this DIC, what are the practical aspects. I thanks everyone for being available in this auditorium when food is available outside. So I truly feel that what you are hungry about knowledge, and that is why you are sitting inside the auditorium. Others are hungry for food for now, but they will immediately come inside. That is what I hope. And let's start with today's discussion. We have this expert panel, Dr. Girish Badarke, hematologist from Nashik. Dr. Shruti Mantri Toshniwal, she is hematologist from Aurangabad. Dr. Manoj sir is here, he is physician, renowned physician from Nashik. Revati madam is also on dais, she is physician from Nashik. And Dr. Nishan Jindal, he is transplant physician from Actrec, Mumbai. So in between also, I want, if anyone has any question, please drop. I want this to be like a dialect. I want this to be more like a practical aspects rather than just throwing various data, various cases. I know last 2 days it was very busy, completely science was discussed. So I just want it to be more like a, going through the question and answer type of thing. So first, Dr. Girish is here. Let's understand from him that how do you define DIC? What the DIC is? He will throw some light on how DIC can be defined.
Because that DIC is death is coming, so I'll not scare with that. Basically, DIC, what happens is it's a systematic activation of coagulation system which starts, and generally there are microthrombi and involvement of microvessels as well as medium-sized vessels. And when that sets in, there is consumptive coagulopathy which can lead to consumption of platelets, as well as there is consumption of coagulation proteins which eventually lead to bleeding manifestation. So on one side there is coagulopathy going on, where there is thrombosis, and then there is bleeding manifestation as well, and it gets uncontrolled because of some underlying causes like infection, which are uncontrolled infections, malignancies, solid malignancies, or maybe hematological malignancies. Sometimes there can be a trauma which triggers this, or massive blood loss. Sometimes we have seen blood loss, massive blood loss DICs, which we see in clinical practice. So these are the common causes, and generally the mechanisms are basically tissue factor activation, which starts the process and then eventually lead to the cascade, and the coagulation start, and then the consumptive coagulopathy sets in.
So thank you so much, Dr. Girish. Rightly said, rather than just, though DIC is very complicated procedure, complicated process going on in your body, but he has rightly pointed out what exactly the DIC is. So in general consideration, disseminated intravascular coagulopathy. It is coagulopathy itself, it is not a kind of disease, but it is the middle process or complication in some disease. Whatever sort of various diseases you all are seeing, some patients are admitted in ICU, some obstetricians are here who see obstetric complications, some surgeons are here who see polytrauma and head injury patients, and in those cases, we routinely see DIC. So it is in the middle of that process where essentially there is imbalance between coagulation, that is anticoagulation and procoagulation, that leads to the massive activation and consumption of coagulation proteins. So we can essentially divide them into two, that is acute DIC and chronic DIC. Many times I just label that patient, it is something like chronic slow low grade DIC is going on, and physician says that हमने तो कभी ये सुना नहीं है. So yes, some cancers, some chronic disorders, in them systemic inflammation is going on, where there is slowly and lasting for several weeks the DIC process goes on. It is more of like thrombotic or clotting predominant thing is there. But when it is acute, it is mainly bleeding because of the consumption of various coagulation factors, as Dr. Girish has already said rightly. So it is not a primary disease, it is because of various disorders or various other reasons which actually stimulate that coagulation pathway. So it may be sepsis, more likely gram negative was initially suspected to be the cause of DIC, but now the prospective control trial have shown us that any infection can lead to the DIC, gram positive, gram negative, parasitic or even viral illnesses. Others are obstetric complications like abruptio placentae, retained fetus, product of conception, preeclampsia, septic abortion. They can lead to severe DIC. Some patients who come with polytrauma, some initially used to feel that it is because of the massive transfusion. Patient comes with polytrauma, they have bleeding going on, you have to give some plasma, cryo, platelet, blood product, blood, and then patient develops DIC. Initially it was suspected to be because of massive blood transfusion, but it is virtually difficult to differentiate whether it is because of the massive transfusion or because of the underlying process, that is polytrauma. Now it looks like it is because of the polytrauma. When tissue factor injury is there, various cytokines get released into the blood, which stimulate your monocytes and endothelial cells, which leads to the activation of coagulation. Particularly our brain, the cerebrospinal fluid contains various things which stimulate coagulation particularly. So head injury patients are very high risk of developing DIC. And the cancer cells, acute promyelocytic leukemia, all of us know that it is very prone to develop DIC, but other disseminated malignancy as well, they also produce DIC. So these are the causes. It is fairly common. If 100 patients of DIC are there, almost 30-40% are because of the infectious and 30-40% are because of the various type of cancers. So to understand pathophysiology, this is the overall pathogenesis. Some activation process goes on in our body and it activates the intravascular coagulation. It leads to consumption of platelets, it leads to consumption of coagulation factor, it leads to fibrinolysis which increases the D dimer, and because of consumption coagulopathy, patient develops bleeding symptoms. Those molecules get consumed forming microthrombi that leads to the various organ dysfunction. So this all churning, this all systemic inflammation is going on in your body, and that is why this process, which is very rapidly going in acute DIC, is very fatal if not curtailed as early as possible. So my next question is to Dr. Nishant or Dr. Manoj, anyone can take up. How do you investigate? Maybe Dr. Manoj can go ahead first. How do you investigate a case of DIC?
Usually we start with the common investigations like fibrogen estimation, platelet count, PT-INR. But these are now old investigations. Now there are several studies which are documented. If we start investigating DIC by our older methods, we may lose some patient of DIC. So nowadays a very innovative tool which have come as a point of care, that is thromboelastography. That has become turnaround in the early diagnosis of DIC and the management of DIC. The thromboelastography came very early in even in 1948, with the German scientist who invented it. But it has really come into picture for the liver transplant and multi-trauma patient. This involves a simple principle where two chambers are put with a sample and a needle is placed, and it measures the viscosity of the blood as the DIC progresses. Early stage, in DIC, there is no viscosity of the blood. So the needle movement in the chamber is very slight. But as the clot progression progresses, the needle movements become more and more. And late stages of DIC, when fibrin degradation happens, again needle movement becomes less. So point of care, this is a very innovative tool, and we should use it along with the other parameters we have been using.
So let's first go for the tech which sir has already mentioned rightly. So this is thromboelastography. Like in every ICU, you supposed to have a ABG machine where you can immediately take the sample, see the ABG, and depending upon that, you can plan ventilatory settings and what patient needs, what patient has to be given. Such type of machine should be there in all ICUs, that is TEG, that is thromboelastography. It is point of care setting where clot formation and clot dissolution, that is fibrinolysis, is measured at the bedside level only within 3 minutes time. So this is the graph which usually that TEG machine gives, and depending upon the various curves we decide, depending upon that shape you decide what exactly is going on in the patient's blood. So these are various shape. This initial, the topmost is the normal where all the angles are normal. But if there is hemophilia factor deficiency is there, the R and K angle gets prolonged, MA angle gets decreased. These are various parameters which machine measures and ultimately gives the graph. Now with more and more development, even that machine gives what is the diagnosis. Even that machine also suggests what needs to be replaced, whether patient needs to be replaced with what you call platelets, cryoprecipitate, or needs to be started on anticoagulation depending upon various things. So these two, in this, as compared to the normal, even in DIC, the thromboelastography machine can give you DIC hypercoagulable state and also hypocoagulable state when it is more pronounced. So this machine can't be available at everywhere. We have to go by clinical suspicion and the routine parameters which can give us the diagnostic clue. Maybe Dr. Shruti can guide us how exactly in routine clinical practice where we don't have the TEG available, when should we suspect and how to go for diagnosis?
Yes, so DIC basically, like sir always said, it is a in between of, so first you have to have a high suspicion before you test for DIC. High suspicion is when you have a patient who is suspected to have DIC. So generally as a hematologist, I get references for thrombocytopenia. So why patient is having thrombocytopenia? When we go into deep, then we can understand what the pathophysiology is going on. So like in obstetric cases, in a sepsis patient, so basically if any patient who is sick in ICU, suspected to have sepsis or suspected to have other like malignancy or something, we routinely do a platelet count, which is very like CBC is always done. Platelet count is a predictive of DIC. There is a score of DIC where we can tell that patient is having DIC or not. So the score includes platelet count, it includes D-dimer, it includes PT, and it includes fibrinogen. So fibrinogen is a very important criteria for diagnosis in DIC. Always we have to look for a peripheral smear where we can see for schistocytes. But there are a lot of overlapping conditions where you get schistocytes, and there are a lot of overlapping conditions where you get thrombocytopenia with schistocytes. Like you have to differentiate your thrombotic angiopathies from DIC. So the main important to differentiate the thrombotic angiopathy from DIC is a PT-APTT, which may be normal in thrombotic angiopathies but significantly deranged in DIC. Also fibrinogen is an acute phase reactant. So fibrinogen, initial phases of DIC may be normal because of the acute phase reactant, but as you have to have a serial monitoring of all those things. So as the DIC progresses, you get a hypofibrinogenemia. So the calculation of a bedside score in all thrombocytopenic patients is very important, and monitoring of the score. So how the score progresses is very important to diagnose DIC.
So very nicely put Dr. Shruti that yes, for DIC, first and foremost thing is to suspect that patient might be going into DIC. Once florid manifestations are there, then just throwing various blood products towards the patient may not be of much benefit. So whenever a patient is undergoing some surgery, post-surgical complications are happening, patient is in sepsis, patient is admitted to the ICU, and serial monitoring of various blood tests that is what matters. First and foremost thing is the platelet count. When platelet count is started dropping, there might be n number of reasons. Yes, we all know post-surgically platelet count can drop to 80,000, 90,000. That is routine thing we see. But still to suspect that is very important and keep them monitoring. If it looks like patient might be going into DIC, some bleeding symptoms, abnormal bleeding from the venipuncture side, some thrombotic episodes might be seen. And in those cases, you have to see D-dimer, PT-APDT, even fibrinogen level, and depending upon that, we have this various scoring system. So this is International Society of Thrombosis and ISH scoring system is there, in which platelet count, level of fibrin marker, that is D-dimer, which is easily available to all of us, the prothrombin time, which might be prolonged in these cases, and fibrinogen level. So these 4 parameters are there, and depending upon that, we just score simply bedside. If score is more than 5, there is more than 90% sensitivity, more than 95% specificity is there, that patient might be going into the DIC. So just these 4 parameters, that is INR, fibrinogen, D-dimer, and first thing which will give you the clue is the platelet count, which is progressively dropping. So depending upon that, you can just straight away score them. If it looks like yes, 4 or 5 scoring is there, you can repeat that on the next day if score is less than 5. If more than 5, high likely that patient might be having DIC, and start to work on it, I would say. So platelet count is typically moderate to severe thrombocytopenia is seen in DIC. Usually they have less than 50,000 platelet count in almost more than 50% of cases. Rather than absolute platelet count, it is usually the trend, that is slowly, progressively platelet count is going down day by day. Yes, one must have to suspect that some inflammation, some systemic motivation is there for that DIC to go on. PT-APDT is also very important. Tell lab that it is very crucial. Even 1, 2, 3 second prolongation is also important for us, and keep a watch. There are various reasons why APTT gets prolonged, because of vitamin K deficiency, abnormal liver function because of liver injury, even impaired synthesis because of various inflammatory things going on in the body. So even at the initial suspicion, starting them on vitamin K is always beneficial because of n number of days of antibiotics. Already post-surgical catabolic state, they have vitamin K deficiency. You give 1 or 2 doses of vitamin K, it starts working in 4 to 6 hours only, and it helps to replenish those vitamin K dependent factors. So PT-APDT is very important. D-dimer is easily available, though FDP, the soluble fibrin monomers, they are not available easily to us, but D-dimer is the thing which is easily available to the routine labs that we can do, and score them with the help of fibrinogen as well. I know fibrinogen is available in very few labs, but still whenever high suspicion is there, there is always a way to find from where we can get the fibrinogen done and start working for the same. Also, always thrombocytopenia is there. Make sure that you ask pathologist to see the smear and give us the insight about schistocytes, because DIC can always be confused with the TTP, microangiopathic hemolytic anemias, HUS, all those things where schistocytes are usually more common. And in them, giving platelet is like adding fuel to the fire. So make sure that you see the peripheral smear to avoid the confusion with the TTP. Thromboelastogram we have already discussed. So this is how usually the DIC picture looks like. These all parameters go here, there, everywhere. And if you score, you can start treating them. So maybe Dr. Revati can take, how do you treat these DIC cases once you have suspected the DIC? Yes, how can we go ahead?
When you suspect DIC, the main crux of the treatment is to treat the cause first. What is the cause of DIC, and you start treating that. But usually our patients are in ICU, critically ill patients, and before we also reach or we get the call that patient is critical or bleeding, staff and RMOs, they already give vitamin K and pause to start with. But we have to give supportive treatment first. We have to ensure about the respiration, temperature, circulation and everything. And then if patient is bleeding, then we go for platelet transfusion. As yesterday we have already come to know about all details from Mrunalini madam. You can opt for RDPs or SDPs. And you can give fresh frozen plasma also. If the patient is overloaded already, then instead of fresh frozen plasma, you can give cryoprecipitates. In serious cases, you can go for this prothrombin complex concentrates or recombinant human activated protein C. The drug's name is Drotricogen alpha and brand name is Zigris. Its half-life is less than 2 hours and it is given in doses of 24 micrograms per kg per hour.
So, thank you so much, madam, for giving the exact insight, how exactly we treat this monster. In our hand, we have first thing, that is, we have to treat that disease which leads to the DIC. So that is what mentioned by madam first, that it looks like whatever the thing, that sepsis, the obstetric complication, the trauma, the cancer, whatever is the primary cause for that DIC needs to be treated. Second thing is that we have to go by the transfusions, the replacement therapy, because we have seen there is conjunctive coagulopathy and all the factors are getting consumpted. They needs to be replaced wisely because already there is thrombotic tendency in the microvasculature. Madam has already told that we can give pause, silate, but with replacement of this blood product. Maybe Dr. Nishant, who is hematologist and working as a transplant physician, can guide us about how to go transfusion or replacement in these patients, whether SDP, RDP, when to use cryo, when to give FFP, what should be the dose of FFP. Maybe Dr. Nishant can guide us.
So like ma'am already said, so it's a fine balance between bleeding and thrombosis. And we need to understand that thrombocytopenia is not antithrombotic. Like patients can have thrombosis even in the setting of thrombocytopenia. So you need to see your patient whether thrombosis is a bigger problem or thrombocytopenia is a bigger problem right now, and the bleeding is a bigger problem. In DIC, like Dr. Uday had mentioned, the bleeding is out of proportion to the platelet count because of the existing coagulopathy. And DIC patients can have really bad bleeding, which is refractory to transfusion support. So if the patient is bleeding and bleeding is the predominant problem, then replacement of deficient factors is the way to go. So replacement therapy would be with FFPs because FFPs will have all the factors as opposed to cryo. But like ma'am said, if volume overload is a problem, then you can consider cryo. But I think it's preferable to give FFP, and the dose is around 10 to 15 ml per kg is the dose which is given over 24 hours during the day. For the platelets, again, you need to correct for the factor deficiencies first, and then if the patient continues to bleed, you can give platelets. That's about the transfusion support in DIC.
Yes, rightly said, Dr. Nishant. Thank you so much. So yes, what we have available with us is the transfusions which we can give. Yes, if patient can't tolerate and if patient can afford, we can have those fancy drugs which are rightly available now at our doorstep. That is the Prothrom, that is APCC, activated protein concentrate complex. But cost of that one dose usually goes more than ₹1 lakh. Already patient is ICU, patient is already on n number of antibiotics, and we do have that expensive drug with us. So first we can start with this replacement therapy, and in that the thing is that we have to give fresh frozen plasma FFP 10 to 15 ml per kg. But even after giving FFP replacement, still patient is bleeding. That does mean that maybe fibrinogen is low, which hardly we measure. It is not available in lab. In those cases, you can straight away go with cryoprecipitate as well. Target for platelet transfusion is usually to keep platelet count more than 50,000 if patient is bleeding. And cryoprecipitate, usually we need 5-10 units as well if patient continues to have the bleeding. So usually it is platelet transfusion, FFP transfusion, and also the cryoprecipitate transfusion. Heparin is very good molecule for us, but in this case, where patient is having bleeding tendency already, to give heparin is really risky. We have to clinically judge those things, and if it looks like rather than bleeding, more consequences are because of the microvascular thrombosis leading to mercury organ damage, we can start with LMWH or even 500 to 750 international unit of heparin per hour as unfractionated over the 18 hours. There are clinical trials, there are prospective clinical trials going on right now, and looks like heparin is the only thing right now we have in our hand when it goes to the DIC, which needs to be given in measured way. So in a nutshell, for acute DIC, you suspect DIC, you have diagnosed that patient is having DIC, but if no bleeding, no evidence of ischemia, start treating the primary disease aggressively, escalate your antibiotics, start to treat that malignancy properly. That is what first thing is needed. If patient is bleeding, give the blood products as and when needed, all three. And if ischemia is there, maybe you can add LMWH to them. If chronic DIC is going without thromboembolism, nothing needs to be done, primary disease needs to be tackled, or you can start with LMWH because you are worried about the ischemic process. But if thromboembolism is already there, patient has to be on LMWH, or even you can start with warfarin or newer anticoagulation. Prognosis of DIC is very bad if not treated in a right time, in a right way. All of us have these patients around us in ICU, in post-operative settings, after our obstetric complications, just to make sure that you suspect that, you diagnose them in time and start treating them will make the difference. If the underlying disease is treated rightly, you just have to support them so that this coagulopathy dies down by itself or by a replacement of factors which are missing in the body. So just to take home message is, this DIC is common, awareness is needed for this thing. We all have to be aware, all have to be suspecting this thing. There are not many treatment options to us apart from this transfusion support. Various clinical trials are going on. Looks like various fancy drugs are there in future in our hand for this DIC, which can be life-saving. But for now, suspecting early, treating that disease aggressively, and right transfusion support is the way forward. So thank you so much for your attention, and session is open for the questions to our expert. Thank you. Any questions about DIC or routine practical problems, you can ask. Yes, Dr. Sadesh.
Some are using it, but probably the guideline is against that. So, few thoughts on that.
Yes, thank you so much for asking this. Maybe anyone from panel can take about the fibrinogen concentrate, Girish, Nishant.
Fibrinogen concentrate, if you are monitoring it properly, probably that can tell us. But again, there are no clear-cut guidelines which are supporting it. But if there is bleeding which is uncontrolled, in spite of all the measures, probably there is definitely a role of using a direct fibrinogen concentration.
The problem with DIC is that the other factors are also down. So
Yes,
it's not
only
the
fibrinogen replacement.
And fibrinogen can add fuel to fire. I just got this point because we need to discuss, because the MRs come and tell us कि आप इसको use करो, but that should not be the case. If required, FFP or cryo can be used, but
Even PCC also has the same problem.
Thing about PCC, that is what
Same
Dr.
problem.
Girish says, yes.
Even PCC
it
also has the
contains
same
activated other factors as well, which can be pro-coagulative or pro-thrombotic, And in those cases, we have to be very judgmental when to use prothromb or PCC,
So,
where
yeah.
to use fibrinogen. As Girish sir has already told, if uncontrolled bleeding is there,
Uncontrolled
and
bleeding
you
is
know
there.
that documented fibrinogen level is very low, as a life-saving measure, in those cases, you can use this.
Along with that, FFP should also be given.
Yes,
That should be
along with
point.
the replacement of other factors, that is
Even
what.
if we give FFP and fibrogen is less than 1 gram, I think that is the indicator to give cryo.
Yes, sir, we
Yeah.
can say that. If fibrinogen level is low, you are giving FFP. Obviously, FFP doesn't contain the fibrinogen. It is always better to give FFP along with that, the cryoprecipitate. Yes. Yes, sir.
Snake bite and DIC.
Very important question. Thank you so much for asking this. Maybe anyone, first physician or the hematologist, can take snake bite and DIC.
So snake bite and DIC is again a very common scenario in patients in hospitals, especially emergency settings in big government hospitals where you find these patients, people, farmers who are working in the farms. So again, like sir has already mentioned, you cannot do much about the underlying cause except for giving the antivenom. So if there's a coagulopathy which is persisting, which is indicated by the whole blood clotting time. So what we used to do was keep in a patient with a snake bite, keep the blood in a glass vial, and if it's not clotting in 20 minutes, it tells you that there is active toxin in the blood. And at that point, anti-snake venom should be given. And the rest of the approach is more like you would treat any other DIC. You have to be cognizant. I think he's summarized it very nicely that you have to look at what DIC is causing to the patient. The DIC can be completely asymptomatic at the time point when you're treating. At that time, you don't need to give any supportive care. If the patient is bleeding, then obviously you need to give factor support. And if the patient is having some evidence of thrombosis, microthrombi, gangrene, then you need to give some antithrombotics while being cognizant that these patients can bleed. But specific to a snake bite, whole blood clotting time, 20 minutes whole blood clotting time is something that you can do at the bedside and decide, take a call on the anti-snake venom.
Yes, thank you, Dr. Nishant, for taking this question. Last month, we had one conference in Aurangabad, small conference, and Dr. Dilip Punde from Nanded district, he was there. He has treated thousands of cases of snake bite, and he is well-known authority in snake bite and all those things. That time, I had opportunity to discuss about this thing with him, DIC and snake bite. So somehow the vasculotoxic snake bite, DIC is very profound. It develops very fast. It is quite life-threatening. And in those cases, though, same thing remains. The antivenom we give, we have to treat as other DIC only, but bleeding is more common, bleeding is more profound, and time is less. So early suspicion, and immediately you just order PTA along with fresh frozen plasma as well, rather than wasting time to become that APTT more than 90. First suspicion looks like it is not neurotoxic, it looks like it is vasculotoxic. Order FFP, give them straight away. Wait for that FFP to get consumed. If patient feeling better, looks like parameters are okay, no, order one more set of FFP along with the cryoprecipitate as well, because hypofibrinogenemia also very common in the vasculotoxic snake bite. So aggressiveness is, I think, that is what makes little bit difference in this. But anyways, for DIC, suspicion and aggressively treating this disease is very important. Thank you, sir, for asking
In
this question.
snake bite, I think another problem is the renal failure. Like vasculotoxic snake bite, all these patients will develop renal failure because of renal vasculature, microthrombi, and direct toxicity. So dialysis also becomes an important component of it. So I think that's more specific to snake bite and DIC.
So sometimes ASV gives us false sense of security that we are given ASV on the time and patient may not progress, but that doesn't happen. Some species don't respond to ASV in India as well as in Maharashtra. So despite giving ASV, DIC progresses and we should be ready with the other therapies.
Yes, rightly mentioned, Dr. Manoj. Yes. Any other question? So I think this is all today's discussion about DIC. Thank you so much for being so attentive and being available. Thank you so much.